question on cor pulmonale, and we broke into it a little bit. We got a better understanding of what it looks like to have isolated right heart failure, which then leads to other issues because of the right heart and its direct connection with how it sends blood into the lungs, right? So when the right heart is unable to send blood into the lungs, possibly because of pulmonary hypertension, then you end up having blood backing up everywhere, getting peripheral edema and liver problems. So now we're going to be looking at more of that, pulmonary hypertension and cor pulmonale. Pulmonary hypertension is elevated pulmonary arterial pressure, more than 25, at rest. It's classified into the following groups based off of etiology. The first one is literally just its own thing, just having straight up pulmonary arterial hypertension. That's it. The other four, groups 2 to 5, are pretty much secondary causes. So you could have increased pulmonary venous pressure from left-sided heart disease. So somebody might have left heart failure, which then causes blood to back up into the lungs, which then causes the blood to back up into the right heart, and then you get right heart failure due to left heart failure. That's group 2. Group 3 is hypoxic vasoconstriction due to chronic lung disease. So remember, in the lung, unlike most other organs, or all other organs, in the lung, when you have a certain part of the lung that's got a lot of bad disease and is not really functional anymore, you do vasoconstriction in that area. And if you vasoconstrict too many portions of different parts of the lung, then that of course causes hypertension because you're vasoconstricting. Group 4 here is chronic thromboembolic disease, right? So chronic embolisms, and this person obviously needs to be on like warfarin long term. And then group 5, pulmonary hypertension with an unclear multifactorial etiology, right? So group 1 and group 5 are both straight up pulmonary hypertension, but only group 1 is primary. Group 1 is primary pulmonary arterial hypertension. The other groups are based off of other causes that are causing pulmonary hypertension. Cor pulmonale is an alteration in structure and function of the right ventricle caused by a primary disorder of the respiratory system, most commonly pulmonary hypertension, right? So this pulmonary hypertension then leads to right heart failure, and right-sided heart failure can occur in severe cases because of that, right? So this is cor pulmonale. Remember from the last question we did in our previous video, a person having left heart failure that then led to right heart failure is not the same thing. The patients will present with dyspnea, syncope on exertion, fatigue, lethargy, chest pain, and symptoms of right-sided heart failure. So up to this point, the symptoms are just general heart failure symptoms, but the right-sided heart failure stuff includes edema, abdominal distension, JVD. They had that nutmeg liver thing, right? So liver problems and whatnot, all from step 1. Patients may have a history of COPD, interstitial lung disease, heart disease, sickle cell, emphysema, pulmonary emboli, and possibly other things as well. Physical exam should show you a split S2. Right, so the split S2 is happening because the pulmonic valve is taking too long to close as opposed to the aortic valve, right? So they're taking a longer time. They're not closing at the same time. And patients may also have an S4, which is a non-compliant heart, just because it may have become more stiff or just because of failure in general. Or a parasternal heave, right? So a heave is often mentioned in questions. More often this is an answer choice than actually something they're describing in the question. So you want to make sure you recall what this is supposed to mean. Patients may also be hypoxemic, especially on exertion. Well, of course, right? Anytime they try to do anything like exercise, going up a hill, walking up the stairs, they're going to just become really out of gas because they're going to be out of oxygen because they don't have enough blood actually circulating through the lung and coming back to the left heart. Best initial test, of course, do an echo. It'll estimate the pulmonary artery pressure and assess right ventricular function. If you do a chest x-ray, it'll show enlargement of the central pulmonary arteries with rapid tapering of the distal vessels. However, this can be very hard for us to see. We don't have enough practice looking for pulmonary arteries on chest x-ray. You could do an ECG, which would simply just show you right ventricular hypertrophy, but the most accurate test is to actually do catheterization. When you do the catheterization for these people, you're going to get the fact that the pulmonary artery has a pressure more than 20. Which is not normal at all. Normal is 8 to 20, usually around 15, 16, sometimes 10. Pulmonary hypertension due to left ventricular systolic dysfunction should have treatment targeted at the heart failure, like diuretics and ACE inhibitors, etc. But here in pulmonary hypertension, the treatment is towards the pulmonary hypertension, not the heart failure. So you have to treat the underlying disease. Supplemental oxygen, diuretics, anticoagulation, digoxin, and exercise should be considered in all groups. But in group 1, which is the one that has straight up primary pulmonary hypertension, you need to give them IV prostanoids or endothelin receptor antagonists like bosentan. So bosentan, it has it in the name, endothelial antagonist, right? Bosentan. Phosphodiesterase inhibitors, which work very much like sildenafil, but these are very specific to the pulmonary artery itself. Some patients have vasoreactivity and respond well to calcium channel blockers as well. For the group 4 condition, where you have thromboembolic disease, surgical thrombectomy is necessary to get rid of any thromboemboli that have occurred, and then the patient should stay on chronic anticoagulation. So now we look at these questions over here. First one on the top, they actually had the answer, right ventricular heave, which we just saw here, right? So they told you that there's usually a parasternal heave. That's in this question. It's an answer choice, right ventricular heave, which if you've never heard of, you may not want to pick as an answer choice. 35-year-old African-American woman comes to the clinic due to exertional shortness of breath. Her exercise tolerance a year ago was walking 7 blocks, but now she walks less than a block before becoming short of breath. She also feels lightheaded when she forces herself to go on. She denies syncope, chest pain, cough, wheezing, orthopnea, nausea, or lower extremity edema. So whatever is wrong with her hasn't exactly become really problematic yet, but the shortness of breath on just walking 1 block is definitely not something good. She's been treated for Raynaud phenomena and fingertip ulcerations for the last 2 years. She also suffers from severe heartburn controlled with high-dose pantoprazole. So all of that actually makes it look like she may have Crest syndrome because she's exhibiting those Crest symptoms right there. So Crest syndrome may be something she's suffering with, but she's managing it pretty decently. Family history is not significant. She does not smoke or drink. Vitals look pretty decent. She's also not overweight. What should be the most expected finding on physical exam? See, and that's a very tricky question because now you get all these answer choices and you have to wonder, are these things going to be present in this patient, or is it a different kind of patient that you would expect to hear some of those symptoms in? So in this patient themselves, they had the answer choices right ventricular heave, which only 50% of people chose, and that was the correct answer. Other answers were ejection type systolic murmur radiating to the carotids. Now, ejection type systolic murmur to the carotids, that's a very specific thing they're talking about, right? That you should know exactly what that's for. Usually you would imagine that in like aortic stenosis, where one systole is happening, you get a burst of blood that comes out of the aorta and it goes in the carotids and you feel the pulsatile, also often referred to as like a crescendo decrescendo murmur. Third heart sound at the apex on end expirations. The third heart sound is S3, which is for heart failure, and I'm sure a lot of people picked it. But this patient doesn't really necessarily have just heart failure because she doesn't have any of those other symptoms like wheezing, orthopnea. Those are definite symptoms of like left heart failure especially. And a wide and fixed splitting of the second heart sound. So fixed splitting usually just occurs in like ASDs and stuff, where it doesn't matter how much air you breathe in, because when you breathe in, usually more blood comes into the right heart, and then the pulmonic valve takes a little longer to close. And that's normal physiological splitting. But if it's fixed and wide, then that's just weird. That would only happen in ASD, where the amount of blood in the right heart doesn't matter because it's going through the ASD anyway, not the pulmonic valve. So she most likely has Crest syndrome, which is strongly associated with limited cutaneous systemic sclerosis. African American patients are most commonly affected by systemic sclerosis, and vascular dysfunction is a prominent component of the disease. Raynaud phenomena is present in about 90% of patients and typically precedes other disease manifestations by several years. Pulmonary arterial hypertension is also common, especially in the limited cutaneous subtype of SS. Pulmonary arterial hypertension results from intimal hyperplasia of the pulmonary arteries and typically presents with progressive dyspnea. There may be exertional syncope due to right ventricular failure and inadequate venous return to the left atrium. Physical exam should demonstrate right ventricular heave, which is an impulse palpated to the So this is the main part actually, right? Physical exam should demonstrate right ventricular heave, which is an impulse palpated to the left of the sternum due to right ventricular enlargement. A loud pulmonary part of the S2 and signs of right heart failure may also be present. The other choices are for aortic stenosis, ejection type systolic murmur, left heart failure, which is the S3 sound, and an ASD, which is fixed splitting. And those are one-to-one associations of those issues. Then this question had a part 2. Walking for 6 minutes causes mild dyspnea and oxygen saturation drops to 88%. This is notoriously seen in right heart failure, right? Because what's happening in right heart failure is your right heart is unable to send blood into the lungs, so then the lungs are unable to oxygenate the blood and send it back to the left heart, and now you don't have much oxygen in the rest of your body, even though your left heart is working fine. When it's just left heart failure, the patient doesn't really have a drop in oxygen saturation. Oxygen saturation is working fine because the right heart is successfully sending blood into the lungs. Lungs are oxygenating the blood, is being sent to the left heart. The left heart just can't send much blood out. But when it does send blood out, it is well oxygenated. So if a person's oxygen saturation is dropping due to exertion, due to activity, that's a giveaway for right heart failure, that you must be unable to actually oxygenate the blood. Right? Dropping in oxygen saturation means that whatever blood is circulating doesn't have much oxygen in it. Right? That's different from what you expect in left heart failure, where you just don't have much blood circulating at all because your cardiac output falls down from left heart failure. Chest X-ray shows no infiltrates. PFT for the liver reveals, pulmonary function testing reveals FEV1 at 95%. And the FEV1 FVC ratio of 84%, which are big numbers. So that means there's nothing wrong necessarily with obstructive or restrictive lung disease. Pulmonary artery systolic pressure estimated by Doppler echo is 65 at rest, right? So they give it away to you. They tell you that normal is 15 to 30. Pulmonary arterial pressure being 65 is pretty big. That's a very high pressure. What will a lung biopsy most likely demonstrate? Any answer choice that has something to do with an artery becoming thicker, right? The lumen of the artery becoming smaller, constriction occurring. So this is the actual answer for what happens in pulmonary hypertension: arterial intimal hyperplasia. Right heart catheterization is the most accurate method of measuring pulmonary arterial pressure, but echo can non-invasively provide a reliable estimate also and confirms pulmonary arterial hypertension in her. The lung parenchyma is unaffected in pulmonary arterial hypertension, which is evidenced by the absence of infiltrates on chest X-ray and a normal FEV1 to FVC ratio. Right? So then they have this table here, and then I added this note that pulmonary hypertension groups 2 to 5 can cause pulmonary venous hypertension as well. Very important little key point to have. There was a question recently where the answer was pulmonary venous hypertension. So these issues, you can see right here in group 2, actually they've written it pulmonary venous pressure. Right? Group 2 is different from group 1 because group 2 is more so related to venous pressure in the pulmonary vein. Pulmonary vein is the one that sends blood back to the left heart, and this is elevated pulmonary venous pressure from left-sided heart failure. So when you have right side heart failure, that's related to pulmonary artery hypertension because your right heart pumps blood into the pulmonary artery. When there's too much pressure in the pulmonary artery, you can't send blood into the pulmonary artery, so your right heart starts to become more strong in attempts of winning. Pulmonary hypertension is very similar to the left side having aortic stenosis or aortic hypertension, right? So the left heart tries to become stronger to pump against that high pressure aorta. This case scenario though, group 2, this is a case where a patient may have left-sided heart failure, and then because they have left-sided heart failure, they can't pump blood out of the left heart, so all that blood backs up into the pulmonary vein, which causes pulmonary venous hypertension. Right? The others, groups 3 to 4 and 5, also can cause pulmonary venous hypertension. Management in those scenarios is directed at treatment of the underlying cardiac disorder, which is what they mention here. Right? Treat underlying disease. You're not just taking care of the heart aspect, you're treating what's making the heart go through this kind of trouble. Next topic, pulmonary thromboembolism. An occlusion of the pulmonary vasculature by a blood clot. 95% of emboli originate from DVTs in the deep leg veins, like the femoral vein. This can lead to pulmonary infarction, right heart failure, and hypoxemia. Right? So pulmonary thromboembolism, very high yield topic. Like a million questions about this in the first aid for step 1 respiratory, and this is like extremely high yield because everything here is high yield. Like DVTs are high yield, people getting fractures are high yield, and obese patients who just end up having hypercoagulability is high yield. So we're seeing now the connection of thromboembolisms with right heart failure. In this case scenario, you're going to be looking for something with the Virchow triad, right? The Virchow triad is related to hypercoagulability. They tell you right here that the Virchow triad is VIR, vascular trauma, increased coagulability, and reduced blood flow. So that's what you're seeing here, right? People can have different problems based off of what's wrong with them, what they do in their lifestyle. So for example, venous stasis is popularly seen in immobility, which is usually truck drivers or anyone who has a sedentary lifestyle overall. Congestive heart failure, where you have systolic heart failure, so you're not really pumping much blood, so there's venous stasis. Obesity and elevated central venous pressure, which is in the brain. Endothelial injury can be due to trauma, recent fracture, previous DVTs, or even surgery. And then, of course, the wide range of scenarios that make a person hypercoagulable. Factors predisposing to thromboembolism are summarized by the virtual triad. Presents with sudden onset subacute dyspnea, pleuritic chest pain, low-grade fever, cough, tachypnea, tachycardia, and rarely hemoptysis, which actually indicates pulmonary infarction. May have a history of immobility, like a long plane ride or being bedbound because of surgery. Exam may reveal a loud P2 and a prominent jugular A wave with the right heart failure. Patients with acute massive pulmonary embolisms will present with hypotension, jugular venous distension, and new onset right bundle branch block, because everything gets messed up in the right side when the lung is all messed up, because remember, the right side is supposed to send things into the lung, but the right heart can no longer really depend on the lung because it's messed up. I also added here that post-operative massive pulmonary embolism can be complicated by cardiogenic shock and lead to death. JVD and right bundle branch block, as they tell you right here, are common things. CNS effects can lead to dilated pupils and unresponsiveness, and the patient will ultimately just die. Best initial step, calculate the modified Wells score. So now this is where a lot of this starts to get very difficult for a lot of students, but generally speaking, just like when we did the previous score thing, the Wells score is not really something you need to memorize or have like a really in-depth understanding of. It's pretty commonsensical stuff. They just make sure they actually teach it, and then they, your job is to make sure that it feels commonsensical. Pulmonary embolism is unlikely if the modified Wells score is less than 4. The best initial test at that point, if you don't think they have a pulmonary embolism, the best thing to do after that is to order a D-dimer test to rule out the pulmonary embolism, right? High negative predictive value and sensitivity, but it's not specific. Remember from biostatistics, sensitive is the snout mnemonic. Sensitive tests rule out disease. So when you don't think somebody has a certain disease, you should just order the screening test that would rule that disease out. When you really do think somebody has a disease, you should order a test that would spin specific. It would actually rule that disease in. So when your Wells score is 4 or less, just order a D-dimer test, and then that'll help you rule out pulmonary embolism, at which point you must think of something else as a problem. Pulmonary embolism is likely if the Wells score is more than 4. At that point, you need a test that can actually rule in pulmonary embolism. So at that point, the best thing is just to do a chest CT. Right? Chest CT is cheap and very quick. You do the CT for the chest with contrast, and you would have high sensitivity and specificity for checking for the pulmonary embolism. But generally speaking, right here, if you did the D-dimer test and D-dimer is high, then you also need to order a CT of the chest, right? Because that tells you now that something was wrong. Even though your Wells score was less than 4, they do have high D-dimer, which means that they could have pulmonary embolism still. So then you come back to this step here, which is ordering a CT for the chest. Theoretically speaking, though, if you did the Wells score and it's less than 4 or less, then they don't have a pulmonary embolism, and then their normal D-dimer comes back as well. You're good to go. You're done. You've successfully ruled out pulmonary embolism, right? So this is kind of a workflow. To understand the Wells criteria, this is what you have: the modified Wells criteria for pulmonary embolism. All right. So now the first few things are so important that they get 3 points each. After which, just addition of any one more yes would immediately put them in the risk of pulmonary embolism. So if they have signs and symptoms of a DVT, any signs or symptoms of a DVT, which shouldn't be too hard to pick out of a question, they instantly get 3 points. If they have tachycardia, you add another 1.5 points. If they've been immobilized for more than 3 days because they recently had some kind of surgery, 1.5 points. If they have a history of getting a pulmonary embolism or a DVT, another 1.5 points. And then any hemoptysis or any malignancy they might have, which of course, remember, having cancer is also a hypercoagulable condition, right? Those also add 1 point. And then in the end, if pulmonary embolism is the most likely diagnosis, that is the one thing you're most suspicious of, that also brings 3 points. This is pretty commonsensical though. If you had a patient who does exhibit signs and symptoms of DVT, you must really think they have a DVT or a possible pulmonary embolism, right? Like there's no reason for you to not think so. If someone presents exactly as being described for their history and physical exam, if they're presenting exactly like that, sudden onset subacute dyspnea, pleuritic chest pain, low-grade fever, cough, tachypnea, tachycardia, and hemoptysis, right? If you're seeing those things, then you would instantly have high suspicion for that, and then the other things would make it a successful more than 4, right? Tachycardia, hemoptysis, you're going to get a 4 or higher grade right away, and you go ahead and pick that this person does look like they have a pulmonary embolism, at which point you should just order a CT. Right, the easiest answer choices are going to be the ones to pick a CT of the chest with contrast. Right, and always remember contrast. Contrast is always there when you're looking for things that are not supposed to be inside your body. Right, like a pulmonary embolism is not supposed to be where you're going to find it. There's no embolisms that you're supposed to find in the pulmonary area. So when you're trying to find the embolism, that is what you're trying to contrast. Same thing with brain tumors. You order that stuff with contrast also because you want to be able to contrast the tumor from everything else. If you're not looking for a tumor, if you're just looking for the brain's shape itself and to see the size of the ventricles, then you order brain imaging without contrast. So contrast is there to help see things that are not supposed to be there. And we're going to see a lot of those questions when we get there. They go on to say more things you can order after this, but the beginning is just going to be this, right? First figuring out the chances of them possibly having a pulmonary embolism, and then ordering the D-dimer or the CT depending on the chances. A VQ scan can be used when CT scan is contraindicated. There are some people you may not be able to do a CT scan for, maybe because they're hemodynamically unstable, right? You can also use it when the patient is pregnant because of contraindication of radiation, right? So these are all scenarios where you don't want to use CT scan, right? And remember, the CT scan has to be with contrast, so the patient has renal failure, you probably can't give them contrast either. So in these cases, you can use a VQ scan, which of course will show you a ventilation perfusion mismatch, because you're going to see that ventilation is working pretty well in most places of the lung, but perfusion is unable to work because one of those arteries has an embolism in it. Right? May reveal areas of VQ mismatch to predict low, indeterminate, or high probability of pulmonary embolism. Sensitive for pulmonary embolism, that means it could rule it out, but not specific, especially if there is an underlying lung disease. Okay. So if you don't see a problem with the VQ mismatch, then you could rule out pulmonary embolism. But if you do see a problem on the VQ mismatch, then there are a bunch of reasons that actually cause VQ mismatch, so it's not specific, right? You can also order arterial blood gases, which pretty much for any pulmonary issue you should. And in this case scenario, you'll see respiratory alkalosis caused by hyperventilation. Remember, these people also have tachycardia, right? They look like they're running a race, but they're really not, okay? But they look like that because they're in pain, right? And they're trying to catch their breath. They're trying to feel more improved, but nothing is helping. Chest x-ray is usually normal. It could show atelectasis, a pleural effusion, or even a Hampton hump, which is a wedge-shaped infarct. You might even see a Westermarck sign, which is oligemia and collapse of vessels distal to the pulmonary embolism. But generally speaking, you probably won't see any of this. You know, we don't have much experience looking for these things, so we won't know what it all looks like. You can Google these things, look up what the Westermarck sign is supposed to look like. This is pretty nice because when you start seeing all these vessels that are dead, that means that the place where the vessels are coming from, that's where you have your pulmonary embolism, right? Because theoretically speaking, as we saw in our let me go right here, right? So what you're gonna see in that, what's it called, Westermarck sign. So Westermarck sign basically means that this is the pulmonary embolism. So you're gonna see that blood was coming up to here, and then the rest of these are gonna be blank. You know, so you'll see the tube, you'll see the tubing, but it won't have any contrast in it. So you're going to get these blank contrast, and then there's going to be more blood flowing correctly in this manner. So when you see these empty tubes, that's when you start thinking of Westermarck sign and a pulmonary embolism. The reason you have these empty tubes is because this person does not have adequate blood flowing through it. So if we look up Westermarck sign, yeah, see, they're pointing out Westermarck signs in all these images, but if I was to post them here for you, you would say I see absolutely nothing because nothing is actually showing. You know, theoretically, it's supposed to be there, but Our eyes are not trained enough to actually cast them. Just to make my point clear, like look at this image. This is showing you a Westermarck sign, but you probably don't see anything. See, it's circled an area that you're supposed to have a Westermarck sign in. But we really cannot make it out. You would have to be a very trained professional to see anything wrong here. Theoretically speaking, it is extra see-through and clear here, so I get that, which might mean that this area's lung doesn't have anything going on around it. That's why it's so clean and you can see the rib cage so nicely. But it's very unlikely that you'll actually cast that in a question. It doesn't really work out that nicely. Westermarck sign would be a bit better answer choice to pick if you just see it as an answer choice verbally. But if you need to identify a Westermarck sign on an imaging thing to get the question right, then good luck. The Hampton hump, that's actually easier to find. The wedge-shaped infarcts, those are easier to find. We've heard of wedge-shaped infarcts before as well, back in step 1 in many different organs. So actually here, yeah, there you go. This is a pretty good image right here. So you can see what they're talking about right here because it's got that shape to it. So usually when you see something in a certain question, you start imagining that there might be some consolidation there, but they'll describe to you that there's no consolidation. Right, so that's the wedge shaped. It's supposed to be like triangle shaped. That's the wedge shaped infarct you're looking at right there. Right, it's actually really clear in this image. What that means is that some artery that was coming here, it branched in that manner, right? And that artery that was supposed to branch in that manner is no longer working. So that artery doesn't bring any blood. So that area that was getting that branched blood supply is no longer getting it. And that's why you get that wedge-shaped infarct. So wedge-shaped infarcts are a common sign in multiple organs, even in the brain, for interrupted blood supply. Okay, so that's your chest x-ray. ECG, usually not ordered, but if they do, they have a very nice little thing to test you on. Most commonly reveals sinus tachycardia, which is obvious. They're going to have a high heart rate. The classic triad of S1, Q3, T3 is rare. That's all they write. So the classic triad of S1, Q3, T3 is rare. Now what is S1, Q3, T3? So I used to have an image for it, but then I took it out because it wasn't really fitting anywhere here. But I could probably put it right here. So S1, Q3, T3. Let me show it to you guys. Okay, this is pretty good. So this is actually really good. It's got it labeled and everything, but you're gonna have to get good at catching this on your own in a big whole whole strip of ECG. So S1 means that you're seeing S waves in lead 1. So this is supposed to be lead 1 up here, but I'm pretty sure it's this is lead 1, this is lead 2, this is lead 3, right? So the lead 1 right here, you have your QRS complex, and the S is too deep. So that's your S wave in lead 1. It's not supposed to look like that. If you look at a normal ECG while I'm showing you this, you'll see it. And then the whole thing was S1, Q3, T3. So in lead 3, you see Q and T waves, right? Q waves that are pathological. Right? Remember how the Q waves are supposed to be? It's supposed to be just a straight fall down. It's supposed to be like Q and then R and then S, right? But this is too deep. The S is too deep here. The Q is not falling like this. The Q is falling like this. You can see it's a bit of a curvature, right? You can keep seeing it. It keeps popping up in the same weird way, right? Like right here, you can see this is curved, okay? And then T3, inverted T waves in lead 3, which is what they're pointing out right there. This is an inverted T wave, right? You keep seeing inverted T waves. T wave is supposed to be another bump, not an invert, right? So S1, Q3, T3 is something that is pretty much a giveaway for DVTs, pulmonary embolism, but very unlikely you'll get tested on that. More likely that, I mean, who knows? You could actually get an ECG just like that one, and then this is what they expect you to see. So we've studied the ECG extensively. Like I've done the cardiovascular videos, I broke it down how to read an ECG, how to understand an ECG, where your odds are supposed to go, what you're supposed to look for. If you don't see any of the things that we've spoken about previously, Then, of course, in conjunction with how the patient is presenting, this is what should come to your mind, and hopefully this is in the answer choices and it'll ring a bell. S1, Q3, T3. Lower extremity venous ultrasound is another final step you could take. Specific and sensitive is one of the best things because it's also very cheap to do an ultrasound to check for DVT. That may be the cause of the pulmonary embolism, but it's not used in the diagnosis of pulmonary embolism because this is just to look for the DVT. Treatment, main thing, anticoagulation, right? Because they're obviously very hypercoagulable, which is what's causing the pulmonary embolisms and the thrombosis from occurring. Acutely, you want to use unfractionated heparin, subcutaneous LMWH, subcutaneous fondaparinux, or direct oral anticoagulants like rivaroxaban or apixaban. In patients with a high probability of pulmonary embolism, anticoagulation should be given before confirmatory testing. You don't wait for all the testing to come in. Use unfractionated heparin in patients with renal failure. Use LMWH in patients who are pregnant. Right? If it's somebody who's chronically having this problem, chronic thromboembolisms, then for the chronic thromboembolisms, LMWH, direct oral anticoagulants, or warfarin are all good to use. But as they say right here, LMWH in pregnancy because warfarin is teratogenic. Now, you might see some of these other answer choices often as well, but you have to be careful in where you pick them. Like an IVC filter is often an answer choice. So let me see if no, there's no picture for that here. An IVC filter is literally a filter you put in your inferior vena cava so that as blood is coming up the inferior vena cava towards the right atrium, blood gets filtered. That way you don't bring any embolic things from the legs all the way up to the right atrium. And once it enters the right atrium, it's going to go to the right ventricle, go to the lung, and then get stuck in tiny capillaries in the lung, causing a pulmonary embolism. So who would you want to put a filter in? This is indicated in patients with documented lower extremity DVT, pulmonary embolism, if anticoagulation is contraindicated. Right? If we can't anticoagulate them, then go ahead and give them an IVC filter. You also put the IVC filter in people who are just getting the DVTs anyway, even though they are anticoagulated, right? Because clearly the anticoagulation wasn't enough for them. Thrombolysis is indicated in cases of massive pulmonary embolism causing right heart failure and hemodynamic instability, like a saddle pulmonary embolism. But again, this is usually not the case scenario. Massive pulmonary embolism causing right heart failure and hemodynamic instability. If the patient looks like they're about to die, then I guess you can consider thrombolysis. And the last thing is DVT prophylaxis. After everything is all good, you need to keep the patient on prophylactic treatment so they don't get another DVT. Treat all immobile patients, give subcutaneous heparin or low-dose LMWH, intermittent compression of the lower extremities, and early ambulation. Right? Don't keep the patient waiting and sitting around, tell them to walk around. Right? We do this for patients that are hospitalized too. Intermittently, a nurse will come, take the patient for a little walk. Should not be laying there constantly for too long. That kind of lack of mobility causes hemostasis and hypercoagulability, and then you get a pulmonary embolism. And that was the end of that. Now we can look at a bunch of our practice questions here. Starting off with, we did these already. This one right here. Alright, so what are we seeing here? 34-year-old woman comes to the emergency department after noticing hemoptysis. Yesterday she developed sudden onset right-sided chest pain and mild dyspnea while getting out of bed. For the last 4 days she has had diarrhea as well as nausea and vomiting after eating in a new restaurant. So that makes you think that something she ate caused her diarrhea and stuff, right? So we got hemoptysis, chest pain on the right side, dyspnea while getting out of bed, and she's had constant diarrhea. And when you see something like this, you really want to first think of Legionella pneumonia. Legionella is an atypical pneumonia that causes diarrhea and pneumonia. That's not normal, right? So when you get that, this is why this is an atypical Legionella pneumonia. And to treat that, you would give levofloxacin. So this could be related to that. I know it's not, but I'm just telling you because you wouldn't know this. You know, if you're reading the question on your real test, you would have to have these suspicions there. Now you keep going. She feels weak and thought her respiratory system symptoms were due to being in bed and inactive. Her chest pain increases with deep breathing. Her other medical problems include HIV. Well, that sucks. So they're really trying to complicate the question now. Heroin use and prior episode of cellulitis on the right arm. Her last CD4 count is actually pretty good. Okay, so CD4 count is not below 200. It is under 400 though. And PPD at that time showed a 2 millimeter in duration, which means she didn't have TB. She has a 15 pack year smoking history. Today she does have some level of fever. Her pulse is fast. Mucous membranes are dry. Breath sounds are diminished at the right lung base. Chest CT is shown, and that's the right side image without markings. So this image was given in the question without markings. What is the most likely diagnosis? So you immediately identify this as a wedge-shaped infarct. You see the triangle? Right, this is a wedge-shaped infarct, which means that some artery that was bringing blood here has some kind of embolic occlusion there now, so it's not working. So this artery, you would usually come here and branch out, and it's not able to supply it. If I drew the same thing on the other side, it was probably some artery that came like this, then branched out like this to supply this area. If I kill this artery, then I kill this area. That's what happened here. Okay, you're also seeing this collection here that you should be able to notice is not on this side. This is a collection of fluid inside, right? So this is all labeled in this image, but normally speaking, it would not be labeled, and you would just get an image like this, right? So you should be able to see that, right? It's pretty obvious here, and you have to figure out what that's supposed to mean. So now you know. So that's your chest CT right there. Pulmonary thromboembolism was a straight up answer to pick, very easy, right? Her acute pleuritic chest pain, hemoptysis, and tachycardia are suggestive of pulmonary embolism. Hemoptysis is a result of pulmonary infarction. Low-grade fever and mild leukocytosis may also occur with pulmonary embolism. Her risk factors for venous thromboembolism include HIV, hemoconcentration due to dehydration in the setting of a recent GI illness. Her CT scan shows characteristic wedge-shaped pleural-based opacification due to occlusion of some distal pulmonary artery. On contrast CT, the pulmonary embolism will appear as a pulmonary artery filling defect. The arrowheads are show an accompanying unilateral pleural effusion. Okay, very nice image. This image in the book is also showing you a pulmonary embolus. Right, so here we're seeing a pulmonary thromboembolism. This is also a pulmonary embolus. How do you catch that? This is an axial CT pulmonary angiogram showing a pulmonary embolus extending from the main pulmonary artery to the right and left pulmonary arteries, consistent with a saddle embolus. Right, saddle embolus. That's what they refer to as saddle embolus. So basically, you can tell this is your aorta, right? That's your ascending. What am I saying? Which one is the ascending aorta? No. So blood comes like that, and it comes down in the front. Yeah, this is your ascending aorta. This is in the front. That's your descending aorta. Right, you also have in here in between, you're supposed to have all your pulmonary vein, pulmonary artery stuff, but there's something in here that's not supposed to be in there, right? And this entire thing is the embolus. This entire little thing here is the embolus. It's not supposed to be there. Okay, and then of course this is your vena cava. Okay, so they're gonna show you images like this, and you're gonna have to figure it out based off of your list of answer choices. You don't necessarily always have to know exactly what you're seeing, as long as you can make a pretty educated guess of what might be happening. Then you have this question where the answer was right ventricular dysfunction, but 30% of people chose pericardial tamponade. But tamponade is a very easy question. You should never really get confused into picking tamponade into an answer choice. You should always be right if tamponade is the answer choice. That's what that means, right? So the 30% of people that chose tamponade here definitely misthought about something. 53-year-old woman is brought to the emergency department after she collapsed suddenly while standing and lost consciousness for about 3 minutes. She recovered spontaneously but was very weak and dyspneic. She also reports left-sided chest pain. There was no tonic-clonic activity or incontinence. She was recently diagnosed with colon cancer on a routine colonoscopy and is scheduled to undergo a surgical resection. Her only other medical problem is hypertension, but she has not been compliant with her medications. Blood pressure is very low, pulse is very fast, pulse ox shows 80%, right? So for some reason, her blood is not getting oxygenated, right? That's a giveaway. We talked about this. Why would your pulse ox ever fall? There's only one real reason the pulse oximetry ever falls. You're not putting enough oxygen into the red blood cell. Now there can be many reasons why that's happening. Why are you unable to put oxygen into the red blood cell? So in her case scenario, given her presentation and given the list of answer choices they probably provided, right ventricular dysfunction seems the most logical thing. That if your right ventricle is unable to put blood into the lungs, then how are you ever going to put oxygen into those red blood cells, right? Other reasons can be not having good, any of those ventilation perfusion issues, not having enough air actually making it to the alveoli, or not having enough blood making it to the alveoli, right? Whichever is unable to make it causes a VQ mismatch, hypoxia. So pericardial tamponade wouldn't explain why her pulse ox is 80%. It doesn't make any sense. Okay. She has right ventricular dysfunction. Her underlying malignancy, which causes a prothrombotic state because she does have colon cancer, and acute presentation of dyspnea, chest pain, tachycardia, hypoxia, and clear lung fields are highly suggestive of a pulmonary embolism. Patients with acute massive pulmonary embolism can present with syncope and hemodynamic collapse. Exam can show an accentuated pulmonic component of S2 and an elevated central venous pressure. Acute, so that's supposed to be high CVP. Acute massive pulmonary embolism results in abrupt rise in pulmonary vascular resistance and subsequently high right ventricular pressures. Elevated right ventricular pressures can cause increased right ventricular wall tension, cardiac muscle stretching, right ventricular dilation, and then you get right ventricular hypertrophy, of course. This increases our right ventricle myocardial oxygen demand and decreases coronary artery perfusion, which all in all is going to lead to symptoms of heart failure, and they completely break down the whole aspect of all this for you. One of the key things is this bedside echo. Bedside echo can show bowing of the septum into the left ventricle and right ventricular wall hypokinesis with sparing of the apex. The presence of right ventricular dysfunction with elevated BNP and troponin levels is associated with increased mortality risk, and that's the worst type of right heart failure to have. Pericardial tamponade may occur due to malignant pericardial effusion, but although pericardial metastasis is common in lung cancer and lymphoma, it is not really that common in colon cancer. In addition, cardiac tamponade will present with hypotension, but it would not cause dramatic hypoxia, right? Pericardial tamponade just doesn't explain why you're unable to put oxygen into your red blood cells, so you don't pick that answer choice, right? That's it. Very straightforward. This here is a breakdown of what you're supposed to do, right? So, for example, you do anticoagulation in suspected pulmonary embolism. Now, to figure out what anticoagulation to do, this is how you have to approach it. Pretty commonsensical stuff. We learned about this in step 1 pharmacology for the anticoagulating part as well. Hematology. So does the patient have any contraindication to anticoagulation? If they do, then you have to do a diagnostic evaluation. You have to confirm the pulmonary embolism, and then since they have a contraindication, you have to give them an IVC filter. So what diagnostic evaluation would you do? That's dependent on the Wells criteria stuff. Maybe you're going to check for CT straight up because you really think they have a pulmonary embolism, or maybe you're going to order the D-dimer stuff, right? So no, not the D-dimer stuff per se. The D-dimer stuff. Yeah. Okay. So is D-dimer or CT? And once you order the D-dimer, you should be able to rule out pulmonary embolism. If the D-dimer comes back telling you that it looks like it is pulmonary embolism, then you still have to order a CT. But in this patient where there's a contraindication anticoagulation, you want to get the ruling really, really quickly. You don't want to wait for too many results to come in because it's not like you can start them on prophylactic anticoagulation. So you would probably jump the gun and order a CT straight up. It's not like the most expensive thing. Just to confirm quicker without wasting time, and then put an IVC filter. Once again, if contraindication is if the patient does have contraindication to anticoagulation, and you did the testing and you found out that they don't have a pulmonary embolism, then you don't need to do anything. That's it. Pretty commonsensical. So this is where you pick the answer choice of IVC filter. Now, if you have a person who needs anticoagulation and they don't have any contraindications to giving an anticoagulation, then you check for clinical suspicion of pulmonary embolism. And what is the B supposed to be? B, clinical suspicion of PE is determined using the modified Wells criteria. If diagnostic evaluation cannot be completed within 4 hours, start the empiric anticoagulation anyway, right? So now you order the testing, you find out it's a very high chance they have pulmonary embolism, start the empiric anticoagulation. If there's a pretty low chance, then you do diagnostic evaluation to confirm PE or successfully exclude PE, at which point you would decide whether or not start or not start anticoagulation. UWorld had the same table as well. Not so bad, pretty straightforward stuff, combining the modified Wells criteria into whether or not you need to give contraindication, whether or not you need to give anticoagulation based off of contraindications, right? So this is combining the two things right here. You can combine it here as well. There's a lot of space up here, so the upper part should have the ideas of what you're looking for in terms of pulmonary embolism likelihood, right? And then depending on how likely it is they have pulmonary embolism, you do what you need to do. Right? So these are the two end factors. These are your two end factors. Either you're going to start anticoagulation, or you're just going to give them an IVC filter, depending on whether or not they have a contraindication to anticoagulation. But if you find out they don't have a pulmonary embolism, then you don't do anything. Very straightforward. Now on the next page we have a whole list of questions. There's a bunch of them to look at to better master these topics before moving on to the neoplasm of lungs. So these are going to be a group of topics that are somewhat relevant as well as good differentials. First one says 45-year-old man is evaluated for recurrent sinusitis and otitis. He has been treated with antibodies and intranasal corticosteroids on and off for the past 6 months, but he still has scant yellow nasal discharge, occasionally mixed with blood. So recurrent sinusitis, otitis, nasal discharge mixed with blood. On review of symptoms, he has fatigue but no fever, chills, cough, or abdominal pain. He's an ex-smoker with a 15-pack-year smoking history. He takes over-the-counter ibuprofen and aspirin for joint and back pains. He's a febrile, chest and abdominal exam are unremarkable. Otoscopy shows erythema and small ulceration in the right auditory canal, so that's pretty weird. Labs give you hemoglobin is low. Platelets are slightly on the higher end. 150 to 400K is pretty normal. He has a lot of leukocytes, protein in the urine, blood in the urine, red blood cells in the urine. His HIV test is negative. What's the best next step in his management? So when you look at all your answer choices and you see all these answer choices about autoantibodies, you come back to the question you imagine, is there any antibody-related question, any antibody-related topic that could be causing recurrent sinusitis and otitis and these weird symptoms he's got overall? And you should be able to think of granulomatosis and polyangiitis. There's a whole group of these things, right? Wegener's and Church-Strauss and whatnot that do cause symptoms everywhere, including the heart and respiratory system. Granulomatosis with polyangiitis causes upper respiratory infection, lower respiratory symptoms, renal symptoms, and skin symptoms everywhere. It's also ANCA positive, and biopsy would be the way you would diagnose it. You would see pauciimmune glomerulonephritis in the kidney. Pauciimmune means with very few immune cells. Granulomatous vasculitis in the lung, and leukocytoclastic vasculitis in the skin. And management is just to start them on prednisone and some immunomodulator like methotrexate. Very straightforward topic. However, as straightforward as the topic might be, there isn't anything crazy that's given in the question that would really make you start thinking of granulomatosis. You're going to have to combine the symptoms and realize that this looks like granulomatosis. All right, you're going to have to do the work for that. Now, in cardiovascular, this is where we saw all of them, right? So we had all these like vascular problems. So we had first here polyarteritis nodosa, which had GI symptoms, right? It also had malaise and was related to hepatitis. So that's one case scenario. Then you have this stuff, right? So Wegener's granulomatosis with polyangiitis does not have a C in the name, so you know it's going to be C ANCA positive. Or you could write it like this, Wegener, with a C, right? The WE for we should remind you that both people are involved, the upper respiratory and the lower respiratory. And the R at the end, which is also bolded here, should remind you of renal involvement. So in Wegener, you get upper respiratory tract perforation of nasal septum, chronic sinusitis, otitis media, and mastoiditis, like our patient. In the lower respiratory tract, you get hemoptysis, cough, and dyspnea. And in the kidney, you get hematuria, red cell cast. See, it's very rare to get a question where you have issues in all three areas. And you have issues in all three areas for this person. He's got the recurrent sinusitis and otitis. He's got nasal discharge. His ear is all messed up with ulceration. And his kidney is all messed up, which is why you're seeing this bad urinalysis. So since everything is messed up, there's only one diagnosis you can really think of, which is this. Right? And you treat it with cyclophosphamide and corticosteroids. So they go on to explain here, the answer was to choose, look for qualitative serum autoantibodies, while 22% chose quantitative immune globulin levels. Now this is not a problem where you would look for globulin levels. That's going to be some kind of immunodeficiency problem where the patient is getting recurrent sinusitis and otitis. But think about it. If you were born immunodeficient for some reason, or you were born with one of those immunodeficiency problems, your recurrent sinusitis and otitis wouldn't start at age 45. It would have started much earlier. So that answer choice doesn't make any sense whatsoever. This patient with recurrent sinusitis and otitis, auditory canal ulceration, fatigue anemia, and microscopic hematuria most likely has GPA, granulomatosis, polyangiitis, formerly known as Wegeler granulomatosis, a small to medium-sized vessel vasculitis. The upper respiratory tract is most commonly involved, resulting in bloody purulent nasal discharge or oral or auditory canal ulcers, sinusitis, hearing loss, and saddle nose deformity. Lower respiratory tract involvement, as seen in him, may cause dyspnea, cough, and hemoptysis as well. Systemic symptoms are common, and labs can show leukocytosis and anemia. Renal involvement in the form of glomerulonephritis, which is why you have blood in the urine, can be delayed from initial presentation and results in hematuria, non-nephrotic proteinuria, and renal insufficiency. Serum ANCA should be checked in all patients with suspected GPA because C-ANCA is most commonly positive in GPA. HIV can increase the chance of false positive ANCA results and should be ruled out. Right? This patient didn't have anything with HIV. So very good question about a very simple topic, but it becomes very hard because you may not have had much experience with it. But it's a very easy topic because of the fact that it's involving multiple organs showing up with disease. This question was great. Only 30% of people got this right, and then others were very confused between what they chose. An extremely old, 81-year-old nursing home resident is brought to the emergency department due to a day of progressive lethargy and shortness of breath. He has a it's a guy. Okay, he has a medical history of hypertension and Alzheimer's dementia. Blood pressure is very low. Pulse is fast. Auscultation of the chest. Excuse me. Auscultation of the chest reveals reduced breath sounds and crackles in the right infrascapular region. There's a 2 out of 6 systolic ejection murmur at the right upper sternal border. Invasive hemodynamic monitoring reveals a cardiac index of 4.4. So cardiac index is pretty much like saying cardiac output, and his is higher than the normal end. Right atrial pressure of 4, which is good, and a PCWP of 6, which is also good. The systemic vascular resistance is low, which is why his blood pressure is low. What is a likely additional finding in him? This is very similar to the other question we did, where the correct answer was you may find somebody with a right ventricular heave. Here in this guy, you're going to find bounding pulses. You're not going to find cold extremities, and you're not going to find a third heart sound. Although third heart sound was probably the most unfair answer choice here, but at the same time, they gave you all these pressure readings. They gave you the hemodynamic monitoring readings. This person does not have heart failure. Their cardiac output would be low. Cardiac index would be low if they had heart failure, which is why they would ever have a third heart sound. Cold extremities are also similar to saying heart failure. Cold extremities mean that you're not pumping out blood to the different parts of your body, so you would have a decreased cardiac output, but that's not true here either, right? Bounding pulses. He has high cardiac output. This patient with pneumonia has signs of septic shock, right? Hypotensive, high pulse, including hypertension and tachycardia. Septic shock causes hypotension from peripheral vasodilation, which leads to decreased systemic vascular resistance. The capillary leak with loss of intravascular volume into the surrounding tissue leads to borderline low right atrial pressure and PCWP. To compensate for intravascular hypovolemia, the cardiac index and stroke volume increase, leading to an increased pulse pressure, which can manifest as bounding peripheral pulses. The findings of bounding peripheral pulses is seen in the early phase of sepsis, known as hyperdynamic phase. Without treatment, this can progress to more severe hypodynamic phase, With patients developing cool and clammy extremities, which is the cold extremities answer choice, due to decreased blood supply as blood is preferentially shunted to the vital organs. But that's not the case scenario yet. This just started for her, for this patient, him, and his cardiac output is high. In most cases, the presence of an S3 gallop indicates congestive heart failure, and that's the other answer choice, and intravascular overload, which he does not have. Theoretically speaking, both of these answer choices will go together. If he has a third heart sound, he would have heart failure, and if he has heart failure, he's going to have cold extremities because he's not going to be pumping out blood. So you could rule out both answer choices, right? But bounding pulses make sense, especially with a higher cardiac index in an 81-year-old person. You're going to feel the pulses very loud, okay? And we're just going to stop here for now. There's two more questions on, actually a couple more questions, a lot more questions. So we'll start with those questions in our next session before going into neoplasms of the lung tomorrow morning.